The next learning objective is given a patient living with HIV, assess the need for opportunistic infection primary prophylaxis. So primary prophylaxis basically means that the patient is at risk of getting the infection but doesn't have the infection yet. We're trying to prevent it from happening for the very first time. So for PCP specifically in HIV patient, if the CD4 count is less than 200, you need to provide the patient with PCP prophylaxis. And the preferred agent is Bactrim. So trimethoprim sulfamethoxazole, the most evidence is with one double strength PO daily for the most patients. Now, if they cannot tolerate that because of adverse effects, only then you can give them a smaller dose. So the smaller dose is likely to help with the adverse effects. In addition to CD4 count less than 200, if someone has CD4 less than 14%, as well as if somebody's CD4 is borderline, so it is above 200, but it's less than 250, and you cannot monitor the CD4 every 3 months, because of whatever reason, so either access to care, because there's a very high chance that this patient might drop less than 200. These patients also could benefit from PCP prophylaxis. Now, in people who cannot tolerate Bactrim even with a lower dose, there are some alternatives listed here. So specifically, you can use dapsone monotherapy. However, we're going to talk about toxoplasmosis prophylaxis in a minute, but basically dapsone monotherapy does not provide prophylaxis for Toxoplasma gondii, so that's important to know. Now, if you use dapsone in combination with pyrimethamine and leucovorin, that also gives you protection against toxoplasmosis. Other options include aerosolized pentamidine, so this is an inhalation, which does not protect against toxoplasma. And then, of course, atovaquone, which must be taken with food for absorption. Now, atovaquone is actually pretty expensive. So typically, dapsone, if someone cannot tolerate Bactrim, typically dapsone would be the next option. If atovaquone is available, typically this can be cost can be a problem. And then how long do you do PCP prophylaxis? So you continue PCP prophylaxis until the patient has CD4 greater than 200 for at least 3 months. And this is obviously, if the patient is not on ART, you have to start ART in order to get the CD4 count up. Otherwise, CD4 count is not going to go up. So here are the recommendations for Toxoplasma. So in order to do prophylaxis, so the CD4 count has to be less than 200, but also you want to see Toxoplasma IgG positive. So prophylaxis is only recommended in patients with IgG positive patient. That means they have been exposed to it, so they're at risk of developing disease. And by disease, I mean specifically encephalitis. So the IgG basically tells you that they've been exposed to the organism, but they don't necessarily have encephalitis. What you're trying to do is to prevent this organism causing encephalitis. So the encephalitis part is what we're trying to prevent. So the preferred agent is also Bactrim. Just like before, you give a double strength once a day. If the patient cannot tolerate it, then a lower dose, including 3 times weekly, may be an option. And if they absolutely cannot tolerate Bactrim, then we have alternatives. So dapsone, as I mentioned previously, dapsone monotherapy is not appropriate. It's not effective. So it has to be dapsone in combination. And then we have atovaquone, which has to be taken with food. So how long to do prophylaxis? So you continue prophylaxis until CD4 count is more than 200 for at least 3 months. Once the patient starts ART. And then lastly, for disseminated MAC, drug of choice are macrolides. So for MAC, you need macrolides. So azithromycin. Pay attention to the dose here. So these are large doses, but once weekly. So 1200 milligrams of azithromycin once weekly. So azithromycin is preferred for prophylaxis because it's better tolerated than less drug-drug interactions. Clarithromycin 500 milligram BID has more drug interactions. Also, it's too many pills, so you have to take it twice a day. Whereas azithromycin you do once a week. It's easier for compliance for the patient. And of course, who needs MAC prophylaxis is if the CD4 count is less than 50, and that's after ruling out active disseminated MAC. And it has to be not on fully suppressive ART. So this is a new recommendation. So before, this ART part is not a part of indication. Basically what they're saying is that ART is so effective that if someone is on ART, there's no way their CD4 would be less than 50. Or if it is less than 50 and you started ART, it's going to go above 50 very quickly. So if someone is on ART, they don't really need MAC prophylaxis. Now, alternative to macrolides includes rifabutin, basically once a day, and the dose had to be adjusted, if there are agents in the ART that will interfere, or I should say interact with this drug. And we will talk more about these class of rifamycins in general when we talk about tuberculosis. And basically for duration, you can discontinue upon initiation of effective ART. So essentially nobody really needs MAC prophylaxis anymore. Now for prevention of CMV, the DHHS guidelines state that CMV and organ disease is best preventing using ART to maintain a CD4 count of at least 100. In fact, they say that primary prophylaxis often with valganciclovir is actually not recommended to prevent CMV and organ disease in people with HIV, even among patients who have CMV viremia. Now, while prevention is not recommended with prophylaxis, it is important to urgently refer patients to ophthalmology if they develop symptoms of retinitis. And in fact, for patients who have a CD4 count of less than 50, it is recommended to have ophthalmologic examination every 3 to 4 months to detect patients who develop retinitis to get them treatment from ophthalmology.